I'm an adult hematologist at Sloan Kettering, and I see most of the MPN patients. So I take care of adult patients. So really, everyone I see is over the age of 18. But I do have a fair number of young adult patients, and obviously patients who were diagnosed as adolescents who are now young adults. And what's sort of become interesting, at least to me in part, is that if you read the textbooks, they say, well, this is an age of 60-plus-year-old people on average. I'm beginning to question that because, in my clinic day when I see patients, 30% of them are people under the age of 40. They shouldn't be there. I mean, there's a referral center bias, right? People come into us for other opinions, but I'm kind of struck by the number of patients I'm taking care of who are in their 20s with these diseases, and so that has to prompt us to ask a lot of questions clinically and biologically. So my presentation is going to be brief, but I think what I'm going to talk about is a couple of the key questions that I get repeatedly from young patients when I see them, and to try to use whatever data there is to try to address that. So how common do we actually think MPNs in young adults, adolescents and young adults actually are? There is some literature out there, and this is a paper I'm going to keep referring to throughout the presentation today, which has come from the MD Anderson group. They looked at their database of roughly 2,000 patients, and they identified about 185 people who fit this definition of young adult. And the age was 16 to 39 versus the older adults who are 40 to 94. And what were some of the characteristics, or what are some of the differences? And this is a really nice table that shows that. So in their data set, their age in the young adults was 33, and it was 64 in the older adults. And roughly speaking, if we look at some of the comparisons and some of the things that were different, males accounted for 35% of the young adults, where they were 54% of the older adults. The number of people, the percentage of patients with JAK2 mutations were 48% in the young adults versus 73% in the older adult population. And I think, as has been already echoed this morning, in terms of ET, if we look at the total percentage of patients, most of the patients in the older group are patients with myelofibrosis, about 70% of them, versus what we see in the younger adult group, whereas the majority are actually ET patients. So that's sort of consistent with what we've been hearing. So those are some of the characteristics that say to us, listen, this younger population might be a little bit different in terms of their disease characteristics. So first question is, if most people with this disease are older, is my disease any different? It's a common question that I get. And there are some differences that have been supported in the literature. In general, there seems to be a trend towards a higher platelet count in younger patients versus what we see in older patients. It's certainly not uncommon that with my younger ET patients, their platelet counts are, at 1 million or higher when I see them, which is not really so typical when we have a newly diagnosed 70-year-old, for example. Aside from that, characteristics have been roughly the same, the percentage of patients with an enlarged spleen, and in terms of the blood counts, aside from the platelet counts, there aren't really too many differences, and these are just ET patients overall. How do the patients do, and what is their risk? So when we think about ET, our biggest concern is blood clots, but also to some degree bleeding. And if you look at this graph here that's comparing the young patients in blue to the older patients in red, and look at the likelihood that a patient's going to have a thrombotic event, the curves intersect, meaning that there really isn't any difference in the rates. We don't see more clots in older or younger patients, and this is up to 240 months in time. At 10 years' time, 98% of the young adults had no clots, and 96% of the older adults had no clots. We always have to be careful when we look at one database because you need large numbers to really begin to have a more definitive story. And so looking at some other data points that have come from other papers. For example, there was another study that looked at young adults and their thrombosis-free survival, and at 20 years, there was sort of more closer to a 10 to 15% rate of thrombotic events. But again, this is at 20 years' time from diagnosis, right? So it is not the majority of patients. One thing to keep in mind is that smoking is clearly a problem in terms of the risk of clotting, particularly in young people. And you can see that if this is the probability of thrombosis-free survival in smokers, it is much more likely that they will have a thrombotic event. It's an important thing to keep in mind, particularly in younger people, because we are seeing younger people use tobacco more often than historically has been seen, but also some of the new smoking modalities. So an important thing to keep in mind. Nobody should smoke, but particularly people with these diseases. What about polycythemia vera? Are there any real differences? One of the differences that is interesting is the amount of the JAK2 mutation. Yesterday we talked about this concept of allele burden, and that refers to what's the percentage of the mutation in the blood. There does seem to be a trend towards a higher level in older adults than in younger adults. Does that make a real difference? It's not really clear to us, what that means overall. There is, again, a trend towards higher platelet counts in younger PV patients versus older PV patients. But aside from that, the other blood counts don't seem to be too significantly different. So, and then if we look at the clotting likelihood, again, that's our primary concern with polycythemia vera. There doesn't really seem to be too much of a difference in the older and younger population, where at 10 years, 97% of both younger and older adults were thrombosis-free. So we begin to get a sense that at least there is no signal that the disease is worse, ET or PV, in young adults. And then we come to myelofibrosis. And again, here there are some differences that might point to differences in the biology of the disease. Again, looking at the JAK2 mutation, the amount of the JAK2 mutation, it does appear to be higher in older adults than it is in younger adults. And the percentage of the patients with a JAK2 mutation here is lower in younger adults, 35% in the younger adult population versus close to 70% in the older adult population. And that might be important because, remember, the mutations do have some bearing on the risk of events. We know that, for example, patients with calreticulin mutations are less likely to have thrombotic events and might be less likely to have their disease progress. So that finding actually can be important when we start to think about the differences in the biology of the disease. In terms of having anemia, older adults were more likely to have anemia and more likely to have an increase in the blast count, which is the leukemia number that we always keep an eye on and worry about a little bit. And one of the also interesting things that I think correlates with the genetics is that we divide myelofibrosis patients into different risk groups. And there is a low risk group and an intermediate 1 risk group and an intermediate 2 risk group and a high risk group. And the risk here is talking about the risk of the disease progressing, either progressing to a different stage or progressing to leukemia. But it does look like that in younger adults, there seems to be a higher proportion of patients in the low risk group as opposed to what we see in the older adults. Looking at thrombosis-free survival, again, here there's really no difference. So again, in older and younger adults in MF with regards to thrombosis, there doesn't appear to be a clear difference looking 240 months out from diagnosis. So the next question is, do I need treatment? Right, and we talked a little bit about this yesterday. When we talk about PV and ET, we risk stratify patients into what we think the risk of having a thrombotic event is. And in the people that we deem low risk, these are patients who are under 60 and never had a thrombotic event, have no cardiovascular risk factors, and we should add have not had symptoms, because symptoms are a trigger to treat if we can't control them through other means. If the high-risk patients are those who are over the age of 60 or have had a thrombotic event. And so in the low-risk group patients, we don't tend to give therapy. Again, the platelet counts can play a role into this, and having symptoms can play a role into whether or not you treat somebody. And our approach, at least in adult patients, and this applies to young adult patients as well, is that if they are in the low-risk category, and they have PV, we do phlebotomies, we give them aspirin. And again, we have to address their lifestyle factors, right? And so things like being physically active, not being overweight, not getting diabetes or hypertension, those are all things, and not taking up smoking, these are all things that are very, very important to address with any adult patient. But I think particularly with younger adult patients, because the time to make a difference in your health is earlier on, not when you're 70 and have diabetes and have had a heart attack. I mean, it's still important to control your factors at that point, but preventative medicine is the best medicine. In the patients who are at high risk, again, over 60 or had a clot, we tend to use a medication like hydroxyurea or interferon, and we give them aspirin and phlebotomize them as they need to be phlebotomized. Now, in ET, it's a little bit different, and in ET, it really has somewhat more to do with the mutation, where patients who have a JAK2 mutation are at slightly higher risk of having a blood clot. And so if we start at the end in the high-risk group, the approach is very much what it is with polycythemia, where we give people hydroxyurea or interferon to reduce their blood counts. And these are patients who are over the age of 60, who have had a clot, and are positive for the JAK2 mutation. Now, if someone is over the age of 60 and never had a clot, but they're negative for JAK2, then the calculus is a little bit different, and we don't necessarily need to give them medication to control their platelet counts. And those under the age of 60 and have never had a clot largely don't need treatment unless there is a symptom reason or they develop a blood clot. Those are really the major indications to give treatment. So this one, I think, is the toughest question oftentimes for patients who need treatment. What treatments are safe for me to take? And there has to be some nuance here because it depends on other factors in a patient's health. We use a couple of different drugs, the hydroxyurea, which we've talked about a lot this morning, interferon, anagrelide, and Jakafi, or ruxolitinib. If we think about safety in hydroxyurea, I know this is an issue that comes up absolutely frequently, particularly in younger adults of childbearing age, but I think universally, people worry about the risk of leukemia. And there is obviously a lot of debate about this, but in the older adult population, there really doesn't seem to be much data to support the idea that hydroxyurea procures leukemia. In studies here, for example, this one here in 25 ET patients who were aged 18 to 49, at 8 years of follow-up, no patients discontinued hydroxyurea due to intolerance, and there was no cases of leukemic transformation reported. It is reasonable to use hydroxyurea in a younger patient, in a younger adult patient. What about interferon? To date, there have been no concerns raised about the risk of leukemic transformation with using interferon. And in many physicians' practices, this is the preferred modality in a younger patient. There are a variety of reasons for this, right? I think that there is some speculation that maybe it can change the disease to some extent. A fair number of people at this point have experience with it. And so oftentimes that's what we do. But again, there are side effects that we have to worry about, like depression, like thyroid issues, like liver issues. And so it might not be the right drug for every patient. Everything requires us to put it into some context. What about anagrelide? Anagrelide has been used for a number of years, and it has sort of become not so much a first-line therapy, but more of a second-line therapy. And in one study, reported here, 35 patients who were 17 to 48 were analyzed after 8 years of exposure to anagrelide. There was really no long-term toxicity noted, but about a quarter of the patients did ultimately develop anemia, which may possibly be attributable to anagrelide. We know that there is some increased risk of developing bone marrow fibrosis on anagrelide. So some concerns remain with regard to its long-term effect and with regard to its tolerability. So we don't tend to use this in the first line if we don't have to. Common symptoms that are seen are headaches and fast heartbeat, sometimes swelling, and sometimes diarrhea. And most of these were actually seen initially when patients are started on anagrelide, but in the long-term follow-up, in this case, which was 8 years, the percentage of that actually did go down. So I think the thing that weighs on patients' minds the most is this question of, will I get myelofibrosis or leukemia? And I think one of the things we talked about yesterday is I think that's the thing that worries the patients and the physicians the most. But the reality is that blood clotting or bleeding issues are more likely to be the complication we face. That doesn't mean we don't worry about this, right? And so what does the data say to us about this? If we think about young patients, young adult patients with ET, their likelihood of developing transformation, I'm sorry, these are ET patients, the likelihood of developing leukemia doesn't seem to be any more pronounced than it is in older adults, which isn't very high to begin with. And at 10 years follow-up, the adult patients, 97% had not progressed to leukemia, and 99% of young adult patients had not progressed to leukemia. So those are good odds. Relatively speaking, we can say maybe there's a 1% to 2% chance at 10 to 20 years. What about progression to myelofibrosis? This is slightly more frequent in the young adult population, but again, the vast majority of patients don't progress to myelofibrosis within the 20-year time span that this data shows you. What do we know can tell us a little bit about someone's risk of prediction? These are findings from the bone marrow and the blood. If we see the presence of fibrosis in the bone marrow when a first bone marrow is done, that's something it's important to pay attention to, because both in essential thrombocythemia and in polycythemia vera, that can sometimes predict an increased risk of transformation to myelofibrosis. There is another number that we often draw when we draw blood, is something called an LDH. And LDH is a marker of cells turning over. And in patients with a higher LDH, there does seem to be more of a trend towards myelofibrosis than in patients with a normal LDH. And we typically see a normal LDH in most of our ET patients. What about polycythemia vera? Here's where we start to see some divergence between the older and the younger patients in terms of the likelihood of their diseases progressing. If we look at the risk of transformation to leukemia, again, from a polycythemia vera standpoint, at 5 years, 100% of young adult patients had not transformed, whereas 97% of older adult patients had transformed, but there was a trend towards an increase in the rate of transformation. So that is statistically significant, and perhaps the PV that we see in older patients is a little bit different. There might be a lot of genetic reasons that underlying that. We heard a little bit about this idea of clonal hematopoiesis, which is something we see in older adults. And if we think about these mutations, right, if we have a JAK mutation and it causes a disease in a young person, it causes a disease in an older person, can there be differences? Yes. And the answer is, why could that be? Because of some context. If older patients have what we call clonal hematopoiesis and they have other mutations that occur as a part of aging, then their disease isn't so simple. It's not just a JAK2 disease, it's JAK2 plus other mutations, whereas we're less likely, we think, to see that in a younger patient. But this is a question that we want to address by doing some advanced genetic studies on younger patients, including adolescent patients. The same thing is true of progression to myelofibrosis, where at about 240 months, 5 years, 88% of patients with PV who are older were still in the PV state, meaning that 12% had progressed, but 100% of the young patients were not. And we see the same thing with myelofibrosis. Remember that myelofibrosis does have the highest rate of progression to leukemia, but it's reassuring to see that in our younger patients, we tend not to see it. At 10 years, 97% of the young patients did not progress, whereas in the older patients, there really was a clear progression to leukemia. 84% of patients at 10 years were still in the myelofibrotic stage. That probably has to do with this figure here in F. Again, we talked about the risk scoring, and it does appear to us that the younger adults do have lower risk disease than the older adults do. And if we break it down even by people who are in that early risk group, the younger patients have a flat line. That means at 5 years, 100% of them have not progressed, whereas unfortunately, quite a number of the older patients had progressed. So there are some differences, or at least this data suggests that there are differences in the biology of the disease of older and younger people, and we need to understand that. This is one of the most pressing questions I get from particularly young adult female patients, will I be able to have children with this disease? There is very clear data to us now that there is an increased risk of miscarriage in patients with ET. The data is variable, but it's suggested that it's anywhere between 9 to 35% of pregnancies. And this is about 2.5 times higher than what we see in the general population. This is mostly first trimester loss. Beyond first trimester, pregnancy loss appears to be uncommon in ET, so it's really the first trimester where we see a difference in ET patients and the general population. And there is data from several studies that have suggested that aspirin actually can reduce that risk of miscarriage. There are 1 or 2 studies that don't agree with that, but many studies have suggested that aspirin might actually have a benefit in terms of preventing miscarriage. If we look at other factors that are associated or that we think about might being associated with pregnancy loss, it actually turns out that things like the platelet count at the time of conception or the white count or the hemoglobin don't appear to actually make a difference, but it is actually the use of aspirin which seems to, at least in some studies, lower that risk. And this is another study showing the SAM data that, again, we have to keep in mind these are really small numbers, but in the patients who had a miscarriage in the study, nobody was treated with aspirin, whereas in the live birth group of patients, 8 out of 12 were treated with aspirin. So that is something to be considered. Now, what if somebody needs treatment while they're pregnant? We prefer not to use hydroxyurea in that situation, and interferon does appear to be safe to be used during pregnancy. There is historic data from a disease called CML, chronic myelogenous leukemia, which is a type of MPN that it is a family member of the MPNs we are talking about here, and for many years people have used interferon to treat patients with that disease when they're pregnant. There are studies that suggest that patients might have an improved outcome if they are treated versus not being treated during pregnancy, and this is a chart showing that in patients treated with interferon, 95% of patients had a live birth versus 75% of the patients who were not treated. So some things to think about. Their maternal and fetal complications don't appear to be very common. Things like having a thrombotic event or having growth abnormalities of the fetus. So those are not things that we see at a high rate in patients with these diseases. In terms of the opposite, in terms of birth control, it's very important that we counsel our young patients that there is a known increased risk of having a venous thrombotic event with estrogen-based hormonal therapy, and that should be avoided. That is our recommendation. Oftentimes, we do suggest a progesterone-based pill if that's needed. There isn't necessarily a lot of data pertaining to this, but it is quite clear that estrogen is a risk factor for a clot. So this is the question that I get from every single patient who I've ever seen with an MPN, and I don't have a good answer to it. How did I get this? It's the toughest question, and the only thing I can ever say to patients is really 2 things. One, there has to be some predisposition in your genome for you to get this mutation, right? We all walk around in the environments, and we're largely exposed to the same things. And so there has to be some predisposition event. And we know that that's actually true for JAK2. There is a genetic change that happens in the DNA of many people who end up with a JAK2 mutation. And so we think that there is something that can predispose people to acquiring these mutations. But the second thing is environmental exposure, right? What do we know historically? We know a couple of things. If we think about Hiroshima, right, where the atomic bomb was dropped, there was about a 3 to 3.5-fold increase in the cases of myelofibrosis that were seen in the survivors who were in the first tier near the center of the explosion. So that was a very strong piece of evidence that says, look, radiation can have an effect in terms of causing the disease. We've seen other things too. There is a cluster of patients with PV in Pennsylvania, right, near a landfill site. And that It's a Superfund site, right? And so that is another piece of data. And the third thing Anna's been talking about is we've been very concerned about Agent Orange because we're seeing a number of cases of MPN in Vietnam vets who had exposure. And there are a lot of different chemicals, benzenes and other things that were components of Agent Orange or what it was dissolved in. And so all of these things collectively make us strongly suspect that there are environmental factors that lead to MPN. Now, the one major caveat with the statement, right, is patients have the tendency then to say, let me think back in my history. Maybe it was that weekend that I was painting a room with the windows closed, right? It's impossible to know the answer to this question. And I know people think about it a lot, but I think we have to do that very cautiously, right? Because there's no way to ever know the answer to that. The last thing, and I think another sort of really fundamental question I get from the young patients is, the longer I have this, the more likely something will happen, right? It's possible, because we look at this data, and it's not a large number of patients. And so, when I have a newly diagnosed 75-year-old, do I think about that person differently than when I think about a newly diagnosed 22-year-old? Absolutely. Your perspective has to be different, right? The goals are the same. We want people to have the longest life and the best quality of life. But at 75, we have certain expectations. We have to be realistic, right? None of us get out of this world alive. But at 22, what does that mean? What is that person's lifespan? What should it be? Those are things that trouble us all, right? And that's why we need to get better treatment. That being said, I think this is an important thing to think about. So we talked about this disease, CML, right? CML is one of the great success stories of modern medicine. This is a disease that when I was in medical school, which wasn't that long ago, and I read the textbooks on CML, the lifespan of patients was 3 to 5 years. Now we have incredibly effective therapy to the point where we think most of those patients can actually have normal lives, right? They're treated with a pill. That is what we want at the end of the day. If we put this into some historical perspective, the chromosomal abnormalities that were responsible for CML were identified in 1960. The actual genes that were part of those chromosomal abnormalities were identified through the late 1980s. We had the first clinical trial of a drug called Gleevec, which has completely revolutionized this field in 1999 to 2001, and the drug was approved in 2001. Since that time, we've had a number of other really successful drugs come out. That time span is 1960 to 2001, right? Let's put this in context of what we're talking about here. JAK2 was discovered in 2005. MIPL was discovered in 2006. From 2005, the approval of Jakafi to treat myelofibrosis, which changes the lifespan of patients with myelofibrosis, was 2011. Look at that time span. Things have changed. The calreticulin mutation that we're talking about was only discovered in 2013. So my point in showing you this graph is that there is reason to be optimistic. We've made a tremendous amount of headway from where we go from genetics to drugs to where we are today. There are a number of clinical trials. I think participation in clinical trials is always a reasonable consideration, not for everybody and not for every type of disease, but it's important to think about. And if you look at the list of clinical trials that are currently open across the United States for MPNs compared to what it was 7 or 8 years ago, it's incredible. So to echo, I think, what a lot of people have been saying this morning about focusing and doing research, these are things that are going on currently, and the efforts are expanding. So that is the message I will leave you with today. I'm happy to take any questions.